Today I'm going to talk about preoperative patient optimization for endourological procedures. This talk is inspired by our recently published review article. This review outlines the current best clinical practices reported in the literature in the last 2 years, and it's not designed as a guideline. And also, I'd like to present our survey. It's not published yet. It's a global survey. The purpose of this survey is to evaluate the current availability of technology for urolithiasis treatment and ureteroscopy and perioperative practice pattern. It's a 43 question survey distributed online among members of Endourology Society, and we received back a total of 191 urologists responded to our survey, and we can see the regional distribution, like from all over the world: North America, Europe, South America, Asia, and Africa. And throughout my presentation, I'm gonna present some of the survey results in relation to the evidence. Objectives that I'm going to discuss today to evaluate the role of scoring systems and nomogram, discuss the timing of urine culture and antibiotic prophylaxis strategies to before endourological procedures to prevent infectious complication, and then measures such as preoperative stenting and alpha blocker to prevent ureteral injury. Then discuss the optimum laser in endourology and the choice of the proper laser before the procedure. So, as you know, in recent or last couple of decades, an increasing trend in stone incidence has been reported recently in published data. With current advancement in surgical technologies and integration of AI, machine learning in healthcare, the diagnostic tools and treatment options become ubiquitous. Application of these technologies can be challenging, so a thorough assessment and careful interpretation of clinical data are essential to deliver patient-specific care. The role of these tools and technologies in preoperative settings have not been clearly elucidated by current guidelines, so the presentation outlines the current best clinical practice published in the last 2 years. To start with is the scoring system. In the last 10 years, several scoring systems have been developed to assess clinical decision-making, patient counseling, and disease stratification to help determine the level of care and to create a uniform reporting system to improve quality of urological research. There are several nomograms and scoring systems used in PCNL to predict the stone-free status and other outcomes. Example of these scoring systems including Guy's score system, the Stone, and the Clinical Research Office of Endourological Society Cruise nomogram. I'm gonna just give an overview of these scoring systems. I'm not gonna go into deep detail. The first one is popular, commonly used due to its simple criteria. Score based on all stones seen, not only these targeted in procedure. Abnormal anatomy is considered as abnormal. Any abnormality such as pelvic kidney, horseshoe kidney, and abnormal collecting system or patient with ileal conduit. And then the patient or the stone is graded from grade 1 to grade 4 according to how complex is the stone. As we can see, there is a diagram, so it's kind of easy for the people to use it. And the other scoring system is the stone nephrolithometry. We can see here the variables used in this scoring system: stone size, tract length, and presence of obstruction calyces and the number of obstruction calyces, and then the stone density, and then a total score is calculated, and the patient is graded whether as low, moderate, or high risk. The Crow's nomogram also depends on the three variables: stone burden. The stone is measured in width, length, and then calculated using this equation here. The stone location and stone count. Some of these scoring systems have been modified to assess the stone-free status in ureteroscopic procedures, and other new systems have been developed too. Here are also like a quick overview of the systems used in ureteroscopic procedure. This RUS scoring system we can see here also depends on the stone size, the lower pool stone location, and the infundibular pelvic angle, the stone number in different calyces, and abnormal renal anatomy, and then the total score is calculated. The Seoul National University Renal Stone Complexity Score, it depends mainly on very specific location of the stone. We can see here like every area in the collecting system has a number, whether the stone in the renal pelvis and superior, inferior calyceal groups, anterior or posterior, and then a score is calculated, and the score can vary from 1 to 12. Rear's scoring system, summary of this scoring system, ranging from a minimum of 4 to a maximum of 10 points, as shown in table 1. A score of 4 points indicates the simplest calculus, while 10 indicates the most complex situation. And this interesting ongoing multi-center international prospective observational study, Dr. Chu and Stone Center is part of it. A prospective recruitment of patients who are undergoing any stone treatment, shockwave lithotripsy, PCNL, or ureteroscopy, that have a preoperative CT that can be used for post-processing evaluation of the stone burden with specified software. The primary outcome in this study is to analyze the stone-free rate, secondary outcome including operative time and complications. So I'm so excited to see the result of this study, as it includes all the procedures and not specific to only one procedure. There are several studies that have compared these scoring systems and nomogram. We can see Biswas and colleagues compared the 3 different scoring systems using PCNL, and they found that all are equally predictive of stone-free status, but small differences between the scoring systems, such as Guy's score system, was found to be associated with length of hospital stay and operating time. Selmi and his group evaluated the 4 nomogram used in ureteroscopy, and the same finding, all predict stone-free status, but they concluded like if you have all the systems available, RUS is recommended, except for single renal stone. The S-risk should be used to assess single renal stones, and for lower calyceal stone, all scoring system can be suitable except stone. So looking back at our survey to see how often urologists using these scoring system in their clinical practice, we found that 21.9% adopt these scoring systems and nomograms in their practice. We move to the second objectives: prevention of infectious complication. As we know, urine analysis and urine culture are the main indicator guiding the perioperative antibiotic therapy and duration of administration. In the last couple of years, we started to hear about next generation sequencing. It's a novel technology to detect microorganisms by identifying bacteria in body fluid by recognition of microorganisms, RNA and DNA. There have been proven several uses and benefits. While in the past, UTI detection focused on single pathogen that cause acute infection, there has been a shift in emphasis toward biofilm-driven chronic infection, which only DNA sequencing can detect these biofilm. Faster detection of microorganisms, especially in high-risk patients, instead of waiting for urine culture results. DNA microbe genome sequence guided prophylaxis helps avoid serious complications of infection that investigated the use of NGS in patients with neurogenic bladder. DNA testing with NGS technology may benefit patients with persistent symptoms of UTI despite having negative cultures. So to evaluate its clinical application in endourology, this prospective study included 84 patients, analysis of preoperative voided urine using both urine culture and NGS, and they found that NGS had a higher detection rate of microorganism in both voided urine and stone culture when compared with a standard culture. However, the specificity and positive predictive value were overall low. So further clinical trials are warranted to determine in which specific perioperative scenarios NGS may be beneficial prior to urolithiasis surgery. Duration between urine culture and surgery, while as we know, urine culture is essential in preoperative assessment of patients with suspected UTI. The optimal timing of urine culture prior to the surgery is still unclear. This retrospective study evaluated 356 patients. The influence of duration between urine culture and PCNL on the risk of postoperative systemic inflammatory response syndrome were evaluated. The duration between urine culture and PCNL did not influence the rate of post-PCNL infectious complication in both short duration group culture taken less than 10 days or the long duration group culture taken more than 10 days. So further studies would be needed to clarify the optimal time point of urine culture in patients with proven risk factor for post-PCNL infectious complication. But is urine culture necessary for every patient? In this study, Groen and colleagues retrospectively analyzed 201 patients and showed that the negative urine dipstick prior to ureteroscopic procedure is sufficient to eliminate the need for urine culture in predicting postoperative infectious complications. Choosing the best antibiotic prophylaxis strategies. As we know, antibiotic stewardship is crucial, and use of antibiotics should be balanced against the ever-increasing threat of antimicrobial resistance. It has been a debate whether a single-dose prophylaxis is enough or extended antibiotic course is required. We can see different practice despite guidelines recommendation. This multi-center retrospective study with a total of 81 patients, the group 1 preoperative antibiotic prophylaxis was given only in 42 patients. Group 2 pre and post-operative antibiotic was administered in 39 patients. And a single preoperative dose of antibiotic is sufficient, and additional postoperative antibiotic don't decrease infection rate after ureteroscopic stone treatment. This is a randomized controlled trial. patients divided into two groups. Group A, 43 patients received 7 days of nitrofurantoin or a culture-based antibiotic plus preoperative prophylaxis. Group B received only preoperative prophylaxis and no advantage found to provide no advantage to providing 1 week of preoperative oral antibiotic in patient at low risk of infectious complication. So from these two studies, no advantage of prolonged antibiotic prophylaxis in low-risk patients. What about antibiotic strategy in high-risk patients with infectious stone? This multicenter randomized controlled trial evaluated patients with clinical diagnosis of infection stones. The primary outcome was the stone-free rate at 6 months. Group A, 20 patients received 2 weeks antibiotic post-PCNL, while Group B, 20 patients received 12 weeks antibiotic post-PCNL. All these patients have had a proven infection stones. Neither 2 weeks nor 12 weeks of postoperative oral antibiotic is superior to prevent stone recurrent and positive urine culture. So shorter is better. The data on best duration of therapy in high-risk patients with preoperative positive urine culture is scanned. So in this study, 220 patients with positive urine culture undergoing PCNL were prospectively registered. Initially, preoperative antibiotic were given empirically. Postoperative systemic inflammatory response syndrome was the primary outcome. Antibiotic therapy of longer than 7 days significantly reduced the risk of infectious complication compared to shorter period of antimicrobial therapy in patients with preoperative positive urine culture. This is a multi-institutional RCT, 123 patients randomized to either 2 days or 7 days of preoperative antibiotics. All patients in these study either have a positive preoperative urine culture or existing indwelling urinary drainage tube. 7 days of preoperative antibiotic versus 2 days decrease the risk of sepsis in moderate to high risk of percutaneous nephrolithotomy. So it's important to know before procedure whether the patient is low risk or high risk. Where the antibiotic prophylaxis strategy can be differ. We can kind of like ask a question: what are the risk factors to consider before the procedure? Several factors have been studied. Here is a summary of what have been found. Bujani and colleagues did a systematic review and meta-analysis, 5,500 patients, and they identified 6 factors: preoperative stent placement, positive preoperative urine culture, ischemic heart disease, older age, longer procedure time, diabetes mellitus as risk factors for increased postoperative infectious complication. Chang and his group did a systematic review, 24,000 ureteroscopies, and they recognize that higher Charleston comorbidity index, female gender, patient with neurogenic bladder, high BMI, prolonged ureteric stent dwelling time prior to procedures. All these are risk factors for increased infectious complication. While in PCNL, Wang and colleagues evaluated 843 patients in mini percutaneous nephrolithotomy, and they found like smaller channel size, such as mini or micro PCNL, and intraoperative evaluation like tear of the collecting system, percutaneous renal channel crossing the renal papilla are risk factors. In another retrospective study, 758 patients underwent PCNL evaluated, and they found that higher neutrophil to lymphocyte ratio, higher stone score, female gender, and positive urine culture, preoperatively history of diabetes are risk factors for increased postoperative complication. Looking back again at our survey, We ask the urologist if they prescribe post-operative prophylaxis antibiotic, and we found that 45.7% of urologists give antibiotic post-operatively after ureteroscopy, and the mean duration of 5 days. Moving to next objective, prevention of ureteral injury. We're going to discuss first the role of preoperative stenting. Both American and European guidelines don't recommend routine stenting before ureteroscopy to facilitate dilation of the ureter and improve ureteroscopic outcome. In our survey, percentage of urologists doing delayed ureteroscopy after pre-stenting 30%, which is actually interesting. Why people pre-stent? Here's a systematic review and meta-analysis evaluated 20 studies involving 5,852 patients, including both stented and non-stented patients. They found that significantly lower risk of complications, mainly ureteral injury, and increased stone-free rate. This is another systematic review and meta-analysis investigated the role of preoperative stenting in Asian and non-Asian subgroups, 14 studies, and 3,800 patients included. So they found that pre-stenting result in a higher success rate for ureteral access sheath placement and minimizing intraoperative ureteral injury and increases stone-free rates. This is a really interesting cross global study, analyzed prospective data from 114 centers around the world of patients treated by ureteroscopy to evaluate the effect of preoperative stenting on perioperative outcome according to the stone location, whether ureteral or renal stones. And they found again the preoperative stenting increases the stone-free rates and decrease intraoperative complications, including ureteral avulsion, perforation, bleeding, and failed ureteroscopic procedure in patients with renal stones, but not in those with ureteric stones. So preoperative stenting is associated, not to forget that, with undesirable symptoms, including irritative symptoms, a secondary procedure, and risk of prolonged stent placement. We have discussed in previous grand round the stent-related symptom and its impact on quality of life. But here is one of the very important issues forgotten: ureteral stent, which associated with severe morbidities, and several measures have been developed to prevent these avoidable events. Kim and his group developed the stent tracking algorithm registry, STAR. Is automatically activated once the physicians enter the stent placement or replacement billing code into the EMR billing system. At 120 days, an overdue notification is generated and sent to the attending physician through an EMR pop-up dashboard and email. In their validation study, they found this algorithm was able to identify all the stents that were unremoved or unreplaced at appropriate time frame. Another measure to prevent and minimize ureteric injury is preoperative alpha blocker, and the presumed mechanism of action is inhibition of smooth muscle contraction and subsequent decrease in intraureteral pressure. Alpha blocker is well known in urology, is recommended by all guidelines in the treatment of BPH, in medical expulsive therapy for stone passage, and even plenty of data available for its role in alleviating ureteral stent symptoms and adjunct post shockwave lithotripsy and ureteroscopy. But what about the preoperative use of alpha blocker? Again, looking back at our survey, we found like 31.8% of urologists prescribe alpha blocker before ureteroscopy. This is a randomized control trial was conducted at two high volume centers. 150 patients were enrolled. The first group received 1 week preoperative alpha blocker, and the second group received only placebo. We can see from tables the need for ureteric dilation were significantly less in patients with alpha blocker, preoperative alpha blocker, and the time of operation also was shorter. For the postoperative parameters, we can see lower urinary tract symptoms and lower need for analgesia in patients with preoperative alpha blocker. This study focused on use of on ureteral access sheath related injury and preoperative alpha blocker. So 100 patients with kidney and upper ureteral stones who were planned for non-stented ureteroscopy were randomized. Patients who received preoperative alpha blocker of 3 days prior to ureteroscopy had a lower rate of grade 2 ureteral injury compared to the counterpart, and significantly lower pain score compared to the control patients. Systematic review and meta-analysis by Al-Sikhan and his colleagues were included, a total of 12 RCT and 1,352 patients. A significant reduction in need for ureteral orifice dilation and increase in patient stone-free status, and facilitate higher rate of ureteroscopic access to the stones were found in patients had preoperative alpha blocker. So talking about laser in endourology, as we know, the holmium YAG laser has been the gold standard for ureteroscopic stone surgery over the past 2 decades. However, holmium YAG still faces limitation with regards to size of stone amenable to ureteroscopic laser lithotripsy. Since 2019, FDA approved the use of thulium fiber laser and started to attract attention among endourologists due to various special physical characteristics and the data in preclinical setting, and has shown early promise that might be that might overcome the limitation of holmium YAG laser. So just a quick overview of the physics behind the thulium fiber laser. It's a long, thin silica fiber doped with thulium ion. It's a dyed laser, excite thulium ions and generate a wavelength at 1920, while the holmium YAG laser is a white light emitted from a flash lamp. This white light interact with the holmium ions bound to the YAG crystals, these purple crystals in the laser cavity, and excites holmium electrons into higher energy. The wavelength emitted by holmium has a length of 2120. When we talk about holmium, it also includes holmium YAG mousses. Holmium YAG mousses, actually, the idea was born in 1994 to allow a higher percentage of laser pulse to reach the target. The idea modulated one pulse to have 2 sub-pulses, each with different peak power. A short, low-energy initiation pulse would generate the vapor bubble, followed by a longer, more energetic and full-strength pulse after the full expansion of the vapor bubble. It wasn't available commercially until 2017. We can see here the difference between the regular Holmium pulse and the Moses pulse, which the first pulse and the second pulse. This video can show the difference between the Moses and technology and Holmium YAG. On the left side, we can see Moses, and right side, Holmium YAG. We can see the difference, how kind of Moses melting the stone, and how Holmium YAG is more of fragmenting and expulsive power. So, owing to physical characteristics we talked about, so thulium fiber laser has a highly efficient design, permits a small, robust, and efficient console, allow for use of a standard electrical outlet, which is available in every OR, not only OR, like in every room. While Holmium YAG is a very large, bulky machine due to need of large cooling system, and use a specific electrical outlet. The wavelength, we talked about that the wavelength of thulium fiber laser is 4 times more absorbed in water, which increased fragmentation efficiency. At this wavelength, also the thulium fiber laser is more absorbed in hemoglobin and give better hemostasis. Thulium fiber laser can operate at a high power range, capable of very high frequency and very low energy, and low peak power of 500 watt, which makes it like 4 to 5-fold higher dusting rate compared to Holmium YAG, while the Holmium YAG peak power is more than 2000. I'm just focusing on peak power because we're going to talk about it later. Here we can see the difference. Actually, on the left is Holmium YAG with Moses technology, and on the right is thulium fiber laser. You see how is fine and small the dusting particles generated by thulium fiber laser compared to Holmium with Moses technology. By the way, this is the same patient, the case of nephrocalcinosis with massive stone burden. I want to show you, like, after a while in the case, we talked about the wavelength and its absorption in hemoglobin. This is why thulium fiber laser is more hemostatic. We see here how it started to bleed with the Holmium Moses. And still very clear vision with the thulium fiber laser. The retropulsion, we talked about the difference in peak power. So there is less retropulsion with thulium fiber laser than Holmium YAG laser. Here we can see the difference. This is on the left side impacted ureteric stone, and ureteric stone on the right side too. Holmium on the right, thulium on the left. We kind of see how the thulium fiber laser is melting the stone more than fragmenting, while Holmium YAG has a more peak power to fragment. This is actually raised the question is, which technology as an endourologist do you prefer? For different stones, different techniques are needed. So if you want like fragmentation and basketing, maybe Holmimiag is an option. But let's see what's the data saying about that. So all of these are preclinical data. But what about the clinical studies? Are there any different in clinical outcomes? This is one of the very first publications in clinical practice about comparing thulium fiber laser and Holmimiag. This is a randomized controlled trial, 120 patients randomized to either ureteroscopy with thulium fiber laser versus Holmimiag. And they found that thulium fiber laser lithotripsy resulted in a significantly higher stone-free rate and shorter operative time. Actually, this study has multiple limitations, but one of the most important limitations, they compared a Holmimiag 30-watt versus a TFL, like when you are comparing a luxury car with a Corolla from '98. This is another retrospective single institution study in pediatric population. 93 cases performed with Holmimiag laser compared to 32 with thulium fiber laser, and they found a higher stone-free rate in TFL cohort compared to Holmimiag. But this study also has limitations, being a single institution study, retrospective design, small sample size, and even use of multiple imaging modalities to assess stone-free status. This is a US-based study, retrospective review of 152 ureteroscopy cases in US. They found a significant reduction of operative time, 12.9 minutes per case, in a TFL cohort, which resulted in a cost saving of $440 per case, and total saving for an institution per year too. So after all of these data, can we state that Holmimiag is dead and thulium fiber laser is the game changer and the new gold standard? Let's see this study before we draw a conclusion. This was published just last week, a randomized controlled trial that compared Holmium Moses 2.0 with thulium fiber laser. They found no significant difference between two lasers in terms of operative time, no difference in rate of complications, or even stone-free status. Here we can see, say like a more fair comparison when you compare to luxury cars. To draw a conclusion, this is a EUA News article we wrote, and it was published in September. We were debating both which laser is best, and we think that despite the evidence that TFL thulium fiber laser may be superior duster compared to Holmimiag, but it's still little evidence to say that one laser is superior to another, especially in the lack of clinical studies comparing two modalities. The lower peak power and longer pulse width make the TFL the ideal dusting laser, while high peak power and retropulsion of Holmimiag still has a role during ureteroscopic lithotripsy, particularly for those surgeons who performing fragmentation and basketing. In real life, There is need and utility for both lasers in clinical practice, depending on the clinical situation and surgical techniques. Back again to our survey, we can see that the most commonly used laser and available laser in practice is holmium YAG, followed by thulium fiber laser, and then holmium MUSES. 69.8% of the responded to our survey use a mix of dusting, fragmentation, and basketing. 20% only dust stones, 9.3 only fragment and basket stones. 79% of urologists had purchased a laser in the last 5 years. 59% changed their lasering technique and practice due to the new laser, whether fragmentation, basketing to dusting, or vice versa. 58% of the responders are planning to invest in a new laser in the next 5 years. More than half interested in TFL, 25% in holmium MUSES. So to conclude, scoring system and software models are essential predicting tools that can facilitate risk stratification and deliver of patient-specific care. Wise choice of preoperative test and proper duration of carefully selected antimicrobial therapy may minimize infectious complication. Preoperative stenting seemed to be beneficial in well-selected patients. Preoperative oral alpha blocker have been observed to improve operative outcome and including stone-free status and low rate of high-grade ureteral injury. There is little evidence to say that one laser is superior to another. Thank you.